This is Alex Ralph again, and we've now reached the pathology section of the endocrine chapter. To begin, let's discuss Cushing syndrome. Remember, the word syndrome just describes a collection of signs and symptoms that are observed in a single condition. Interestingly, Cushing syndrome can be caused by a number of different things. This is in contrast to Cushing's disease, which only has one cause. But we'll talk more about this later. The basis of both Cushing syndrome and disease is that there is an excess amount of cortisol. And to understand the causes of this, we will be drawing on your knowledge of endocrine physiology. If you haven't yet watched those lectures, you may want to briefly review those concepts or watch the videos so that what we discuss in this section will be easier to understand. So what causes someone to have excess cortisol? The most common cause by far is exogenous administration of steroids. Steroids are useful drugs that doctors prescribe for a variety of conditions, but unfortunately, if used over a prolonged period of time, they can lead to Cushing syndrome. Although less common, there are instances where the body itself is making too much cortisol, and the most common cause of this is a pituitary adenoma. The net effect is an increase in cortisol levels. What do you think is being produced in excess by the pituitary adenoma? If you're thinking ACTH, then you're absolutely correct. This is because the pituitary gland, specifically the anterior pituitary, secretes ACTH, and then ACTH will stimulate cortisol production in the adrenal gland. Specifically, when Cushing's occurs as a result of ACTH secreting pituitary adenoma, we call this Cushing's disease. Be sure to remember that Cushing's disease only has one cause, while Cushing syndrome can be from anything else that might cause elevated levels of cortisol, including exogenous administration of cortisol and other mechanisms such as ectopic ACTH secretion from a non-pituitary tissue, and this can be seen in small cell lung cancer. Also, you can have tissue that is producing cortisol, which leads to the excess. And an example of this would be adrenal adenoma or carcinoma. Now remember, we often use a 24-hour urine-free cortisol test to screen for Cushing syndrome, but this does not tell us the underlying cause. So we must rely on our knowledge of endocrine physiology and focus on the levels of ACTH in the serum. In the case of a patient taking exogenous steroids, what do you think the effect of these glucocorticoids will have on the pituitary? Well, similar to cortisol, they will have a negative feedback and cause the pituitary and hypothalamus to decrease production of ACTH as well as CRH respectively. The net effect of this will be low ACTH levels. Similarly, if the adrenal gland produces too much cortisol, you will also have a low serum ACTH for the same reason. Meanwhile, if the underlying problem is in the pituitary gland or a malignancy, you will have a high serum ACTH level. In order to differentiate the causes of high ACTH levels, clinicians can perform what's known as a dexamethasone suppression test. Dexamethasone is a synthetic glucocorticoid, and it acts similarly to cortisol in that it can suppress cortisol production through negative feedback of ACTH production in normal individuals. To perform the test, we start by measuring the patient's basal cortisol levels. Then we measure cortisol levels after administering low dose of dexamethasone or after administering a high dose of dexamethasone. Typically, the dexamethasone is injected at night, for example around 11 p.m. Then cortisol levels are measured in the morning around 5 a.m. Do you know why the cortisol levels are measured in the morning? This is because they are normally highest at this time, and the suppressive effects of this should be most noticeable at this time. In a normal person, what do you think will happen to the cortisol levels after we give dexamethasone? Cortisol levels will be lower because of the negative feedback on the ACTH production. What do you think we will see in a patient who is taking exogenous steroids? Well, we should see no change. Now, if a patient has Cushing's due to the other causes we listed earlier, they will have no reduction in their cortisol levels with the low dose of dexamethasone. In these cases, a high dose of dexamethasone is needed to help us determine the cause of excess cortisol production. Let's say we give the high dose of dexamethasone and now see a reduction in cortisol levels. We then know that we were able to suppress ACTH production. This occurs in the setting of Cushing's disease. Remember, this is due to increased ACTH production by the pituitary, but this can be suppressed when we give a higher dose of our cortisol-like medication, dexamethasone. Now we're left with two other possible causes of Cushing syndrome. One is if we have ACTH that is being produced by ectopic tissues, such as in the case of malignancy. Do you remember from our study of respiratory pathology which type of lung cancer is associated with this? Small cell lung carcinoma. It turns out that these tumors that produce ACTH do not respond to the negative feedback of cortisol. So despite giving a high and low dose of dexamethasone, you will still have elevated cortisol levels. Similarly, an adrenal adenoma producing cortisol will not be affected by the administration of dexamethasone. But what you should note is that at baseline, the ACTH levels are low, just like a person who is taking exogenous steroids. So now that we've discussed the causes of Cushing's, let's talk about the effects of cortisol excess on the body. The way I like to approach pathology is not by memorizing the associated symptoms, because, let's be honest, it's pretty hard to do. So what I'd like you to do is follow along with me and think about why you see these changes. Remember, boards are not about reciting facts, like Cushing's disease causes abdominal striae. They expect you to know that already. What they want to see is if you understand why these effects occur, and that's what I hope to teach you. So let's get started. Let's take a look at this picture of a patient with Cushing's. You may note that this patient is overweight. So the patient has obesity and fat deposition, particularly around the trunk, and the upper back, which is known as a buffalo hump or interscapular fat pad, and on the face, leading to a moon face. As you may remember, cortisol stimulates gluconeogenesis, which leads to hyperglycemia. The body responds to hyperglycemia by releasing what hormone? Right, insulin. And it is this release of insulin that leads to increased deposition of fat in tissues. You notice that the patient's legs are also quite thin, and this is because of cortisol's effects on muscles. It causes increased protein breakdown and release of amino acids to be used for gluconeogenesis. This in turn leads to muscle weakness. The other thing I mentioned in the previous lecture is abdominal striae. Do you remember from our physiology lecture why the skin becomes thin? This is because cortisol inhibits fibroblasts from producing collagen. There are some other effects of high cortisol levels that we want to remember. One is patients can develop hypertension. This is because if you remember from the cortisol synthesis pathway, the precursor to cortisol is 11-deoxycorticosteroid, 11-DOC, which acts as a weak mineralocorticoid. Mineralocorticoids, such as aldosterone, promote sodium retention. 2. Cortisol causes hyperglycemia, which stimulates the release of insulin, and over time patients can develop insulin resistance. And 3. Cortisol can stimulate bone resorption, which places these patients at higher risk for osteoporosis. There's also the immunosuppressive effect of cortisol, which we discussed in the physiology lectures. So, these patients are at increased risk for infections. Lastly, women can present with menstrual irregularities, and it is thought that this is because cortisol may block GnRH release. We're going to transition now into some diseases of the adrenal glands. Hyperaldosteronism, as the name suggests, is a disease of extremely high levels of aldosterone, which you will recall is produced in the zona glomerulosa of the adrenal cortex. This can either be primary or secondary. Primary implies that the adrenal gland produces too much aldosterone, and secondary implies that there is an increased signal leading to excess aldosterone production. This concept of primary versus secondary disorders is very important because examiners love to challenge you by putting both forms as answer choices. Primary hyperaldosteronism, also known as Cushing syndrome, is usually due to an aldosterone-secreting adenoma. What do you think are the effects of high levels of aldosterone on blood pressure? Well, this requires you to remember our renal physiology and how aldosterone affects the resorption and secretion of electrolytes in the collecting duct. If you recall, aldosterone stimulates the resorption of sodium, and that is shown here. And this helps maintain blood volume by drawing water with it, and as a result, blood pressure will go up. Interestingly, patients with Cushing syndrome do not become hypernatremic, and this is due to what is known as the aldosterone escape phenomenon. This occurs because when there's an increase in blood volume, it stimulates the stretch receptors in the heart to release ANP, or atrial natriuretic peptide. And natriuresis means that you lose sodium in the urine. So that is why these patients do not get hypernatremic, nor do they have peripheral edema. This is a key point to remember because the boards will tempt you into thinking that the sodium levels will be elevated, but remember they are usually normal or slightly elevated. When thinking about hyperaldosteronism, do you remember from pharmacology what drug we might use to help treat this condition? Right, spironolactone, a competitive aldosterone antagonist. Patients can also have too much aldosterone as an effect of excess adrenal stimulation. This is known as secondary hyperaldosteronism. You should remember that angiotensin II increases the production of aldosterone. And do you remember what stimulates the production of angiotensin II? Right, renin. So if you have a high renin level, this could be an underlying cause of hyperaldosteronism. Now there can be a lot of reasons why renin levels are elevated. For example, the body may be responding physiologically to decreased intravascular blood volume, which is detected at the level of the kidneys. Do you remember some of the conditions associated with detection of low intracellular blood volume? You might be thinking renal artery stenosis, chronic kidney disease, congestive heart failure, cirrhosis, nephrotic syndrome. Also, there are rare renin-secreting tumors of the juxtaglomerular apparatus. These conditions will be reviewed in your renal lectures at a later point. Okay, now time for a flash quiz. You suspect that your patient has Cushing syndrome and order a 24-hour urine cortisol test, which turns out to be elevated. What is the next test you should order in order to help you determine the source of the excess cortisol? The answer is the dexamethasone suppression test.